I asked AI to help me develop a tool that would help illustrate some of the different important information that was necessary to study during ophthalmology residency. I'm pretty impressed with what it's generated so far, and this is what's called a graph seed author. So basically the idea is that this is just to help create some flashcards and other resources down the road. So it's not a fully functional app yet, but it gives me a helpful outline to demonstrate how to connect all of the various elements of what you're supposed to be reading and how it ties in together to build a much more robust relational understanding of all of the knowledge that we have to learn. So I figured I'd use the example of non-arteritic anterior ischemic optic neuropathy, or NAION. I have the 2025 to 2026 BCSE for neuro-ophthalmology pulled up here just to help give us an idea of how to read through it and then how to fill out an outline similar to this. Depending on the type of concept that you're going to be studying, you may need different information. So we're going to be filling out a disease node this time, but we could definitely walk through what anatomy looks like, a physiology type of point, clinical sign, symptom, diagnostic test, etc. So all of that becomes really important because, as you'll find out, everything kind of ties together. And that becomes very important as we're trying to study and grow from just being able to answer practice questions to understanding how this all links together clinically. All right, so we'll just start off by creating a new entry. We'll call it non-arteritic anterior ischemic optic neuropathy, and the abbreviation is NAION. Another way people abbreviate is NAAION, like that. The primary domain is neuro-ophthalmology, and then if there was any sort of overlap, so for example, thyroid eye disease might predominantly live in the oculofacial and plastics section, but it has overlaps in neuro-ophthalmology, strabismus, and a few other places. Okay. The priority, of course, is extremely high yield for the OCAP, and then the Bloom's taxonomy ceiling just has to do with how deep of a knowledge is expected for this particular entry. And so for NAION, you're going to be seeing it quite a bit in ophthalmology. So I would say that you probably, at least to the evaluate, if not the create level. I'm going to select create just because for people who might be doing fellowships, etc., they might be under that create level. Okay, so we need a concise one-sentence definition for NAION. So I'm going to scroll back up here a little bit because it gives us a little bit of a definition of anterior ischemic optic neuropathy here, which basically tells us that this is a sudden onset vision loss related to ischemia to the optic nerve. So I would say that it is basically a ischemic injury to the optic nerve head, resulting in sudden vision loss and optic disc edema. And because it is the non-arteritic subtype, we'll call it non-arteritic ischemic injury to the optic nerve, which is a little bit tautological. You know, this basically defines itself that way, but it is a vascular injury related to focal ischemia. So we'll say we can change that terminology to say non-perfusion injury, perhaps. There's a whole bunch of different ways we can describe it, right? And that's still fluid, and so we can always go back and update that later. Underlying mechanism. So if we go back over here, see over here it kind of describes that. It's thought to be related to compromised optic nerve head microcirculation in eyes with structural crowding of the optic nerve head. And there's some histologic findings that suggest maybe the area of infarction is in the scleral canal and then results in a localized compartment syndrome. Now, all of these are theorized, and that's something that doesn't always translate to the textbook description, but we'll add that in there, that the mechanism, we'll say exact mechanism unknown, thought to be related to structural crowding of the optic nerve head and compromised optic nerve head microcirculation with potential local compartment syndrome effect. So the anatomical substrate or structures primarily affected, that's the optic nerve, right? Incidence, prevalence, and demographics, so we put all of that in here. Most common cause of anterior ischemic optic neuropathy. Mean age 60 years old. And I'll put in parentheses because it says up to a quarter of the cases are in patients younger than 50. So 25% are younger than 50 years old. Annual incidence approximately 6 to 10.2 per 100,000. Okay, diagnostic criteria. This is a diagnosis of exclusion, right? And what does that mean? So we have to the clinical presentation should be consistent with anterior ischemic optic neuropathy, sudden or subacute painless unilateral vision loss with evidence of optic nerve dysfunction. I'll put in brackets here some of those things: decreased visual acuity, decreased color vision, presence of relative afferent pupillary defect, visual field defects. Right? Clinical course should be consistent. That's going to be resolution of disc edema within 6 to 8 weeks. No further regression of vision loss beyond the extent of optic disc edema. All right, and then I'll put that part in parentheses, right? But then the other areas of diagnosis of exclusion. And again, you may be wondering, where am I coming up with all of this? This is really just because with me having, or with my with neuro-ophthalmology being my subspecialty, this is stuff that basically just comes to mind as soon as I work through this diagnostic criteria description. So, must rule out giant cell arteritis and other forms of vasculitis. From lab studies such as ESR, CRP, platelets, to temporal artery biopsy. Just rule out optic neuritis in appropriate cases. MRI, brain and orbit without contrast, with suppression. Serologic tests as appropriate. Must rule out neuroretinitis in appropriate cases. Okay, and we'll get to some of those other things when we go to mimics and differential diagnosis and such. All right, so here comes the risk factors. So under risk factors, we have quite a few listed here, right? And it's nice in this textbook because it tells you NAION is associated with the following risk factors. So we can just type those in: structural crowding of the optic nerve head, disc at risk, right? And there's diabetes, systemic hypertension, hyperlipidemia, obstructive sleep apnea, optic disc drusen. And then we do not have to worry about putting in carotid and cardiac evaluation on here. And then hypercoagulable disorders can cause it in rare cases. So we'll put that in as a rare finding. Global disorders, rare. Okay, and then nocturnal hypotension has been suggested as a precipitating factor, but this remains controversial. Okay, so those are all kind of nuanced, controversial stuff. So we'll see if there's some area down here where we can put those in. Okay, genetic associations, none. So we'll leave that blank. Symptoms. So we have sudden vision loss. We'll say sudden monocular vision loss, as even though you can have sometimes bilateral disease, they're rarely ever simultaneous, except in some systemic hypotensive states. So maybe we'll still call it sudden vision loss, and then in parentheses mostly monocular, right? And then it's painless. Visual field defect is present, right? And then clinical exam findings should see an RAPD. Visual field defect, optic disc edema, and I'm going to say it's hyperemic because that's what it says over here. Looks like commas also do that. Optic disc edema, diffuse segmental, and usually initially hyperemic. Okay. And then another important point is that the contralateral eye has small cup disc ratio less than or equal to 0.3 or absent cup disc at risk. Okay, so I think that ends up putting in most of that. We'll put in vision loss, and we can put some of this nuance in here. Visual acuity better than 2200 in more than 60% of cases. Color vision loss if fixation is not spared. Okay, so that kind of describes the clinical exam findings, the symptoms, some diagnostic tests now, right? It talks a little bit about some of these other things. So what are some of the diagnostic tests? Usually visual field defect. So what does the visual field see? Tells us the most common pattern of visual field loss is an altitudinal defect, but any pattern may be observed. So we can say visual field altitudinal defect most common, and then other any pattern possible, right? And we'll see. I don't believe that it really tells us, it doesn't tell us anything about any other kinds of diagnostic tests, but as you might imagine, the OCT RNFL shows early thickening, late thinning. Fluorescein should show leakage of optic disc at the optic disc. Normal choroidal perfusion, and that becomes important in differentiating. MRI is usually normal, right? So the optic nerve usually appears normal 95% of cases. Enhancement or restricted diffusion of intraocular optic nerve head. Okay. All right, so then the differential diagnosis here. So could be arteritic anterior ischemic optic neuropathy. It could be, we have to differentiate that with optic neuritis, neuroretinitis, amiodarone optic neuropathy. As you can see here, amiodarone can trigger toxic optic neuropathy with optic nerve head edema, right? And could be some other toxic optic neuropathy as well, right? And I would say optic neuritis generally encompasses all other kinds of inflammatory optic neuropathies, but we can still include that. Inflammatory optic neuropathies, just so that way it captures that information, and then some infiltrative optic neuropathy, radiation optic neuropathy can sometimes show disc edema as well, and posterior uveitis, which can also cause vision loss and disc edema that can look a whole lot like ischemic optic neuropathy. So I think that's a pretty good differential diagnosis right there. Obviously, it all kind of shifts and changes based off of the presentation. So workup and investigations. I guess we should also put in here labs negative for optic neuritis or vasculitis. Right? So workup, investigations must rule out vasculitis or optic neuritis. So that's the general principle. And then we'll talk about ordering SED rate, CRP, CBC, and then MRI, brain orbit with and without contrast with fat suppression. Infectious, inflammatory labs as appropriate. Okay. Then I'm also going to put in here we'll have to include not the things that are not indicated in a separate section. Treatment options, no proven treatment, right? It comes back down here to here. There is no proven therapy. Treatment goals are going to be risk factor optimization, right? So that's what this is saying. And then also we need to maybe include in here aspirin reduces risk of brain stroke with patients with underlying vascular risk factors, but okay, so that just kind of helps describe the treatment options there. And then under treatment goals, there's risk factor optimization. We can include in there monocular precautions and visual rehabilitation for those who need it. The prognosis and natural history comes back over here. So so it first talks about up here that there may be, the initial course may be static or progressive. So initial either static or progressive. Progressive is about 12%, so static would be 88%. Okay. And then the progression, it occurs while the disc edema is still present. Okay. And then after that, once visual function has reached lowest point, vision either remains stable or can improve 43% with visual acuity worse than 2064. At presentation, regained at least 3 lines on Snellen eye chart within 6 months. Okay, so that's thing, an important thing. Recurrent episodes of vision loss in the same eye 3 months after onset, rare, 6.4%, and then 5-year risk of contralateral involvement is 15%, 15 to 20% in some cases. Okay. So key clinical trials, so that in this case it's the IONDT. Okay. There are several other studies that we can always include, and we can add to those as we read more about it. So this next part is pretty cool because it's helping us describe the clinical course over time and gives us a disease fingerprint. So helps us get some idea. So we'll say this first one is our typical static with, so that means initially there's no progression and there's no improvement. Okay, so over 12 weeks, or if we want to, we can go to, what is that? So that's 3 months, 6 months. So we could do a 6-month period here, right? And then go initially, we'll say if roughly about 2070-ish, and it declines over that first week, and then it stays basically all the way there, right? So that's the first series. The second one might be static, and there is improvement. So it declines initially, but then it improves 1, 2, 3 lines or more, right? And that would be what it looks like over 6 months. Okay. Actually, I'm going to clear this and start over. Okay. So it starts out here like that. And then next one will be static with improvement. And it usually doesn't start improving until a little bit later, but maybe it improved a little bit, and then we'll see some improvement over that period of time, right? So the next one will be progressive, no improvement. So in those cases, it might start off here, and then over the course of the next few weeks, declines a little bit further before it bottoms out, right? And then last one, progressive with improvement. So again, kind of follows that same curve, but then over time may improve. 1, 2, 3. Okay? So that just kind of gives you a visualization of the clinical course. And that becomes really important because this curve is going to look very different for optic neuritis, which is going to look different for a retinal detachment, which is going to look different than corneal hydrops or keratoconus. And just being able to visualize this and think about how the disease progresses or changes over time helps you understand the best way of managing your diagnosis and your differential, because this is going to look way different than, say, a compressive optic neuropathy or a glaucoma. Okay, so expected nadir or worst low point at about 8 weeks, right? And then here's a few nuances, right? So most common visual field is most common. So we'll say the most common visual field is an altitudinal defect. So like that. Let's see, what other things can we do? So variant, exception, caveat, pearl, pitfall, red flag. So we'll say pearl. So that might be some of these starred areas, right? So why don't we start from the top here? So the pearl here is contralateral optic nerve head. Typically demonstrates small or absent physiologic cup. That puts it as a disc at risk. Maybe another pearl here. Carotid and cardiac evaluation not indicated. Neither are proven risk factors for NAION. Right? We can say red flag. And then that goes back up here to say within 6 to 8 weeks, the nerve edema the nerve becomes atrophic. Persistence of edema past this point may suggest an alternative diagnosis. So persistence of optic disc edema past 6 to 8 weeks may suggest alternative diagnosis. And let's see, maybe a pitfall would be, say, NAION is a diagnosis of exclusion. Other causes of optic neuropathy similar to NAION must be ruled out before diagnosis is established, right? All right, so those are all kind of some basic things. There's also some mnemonics that if you have, or other kinds of memory aids, and then here are some notes. So in these notes, and we can even put in here, we'll put on here, actually I don't think we'll add those just yet, right? So maybe under authoring notes for now, we'll also include some of these other controversial things. Internal hypotension suggested as precipitating factor, but is controversial. association with PDE5 inhibitor drugs used for treating erectile dysfunction is controversial. Okay. Then I'm also going to put under pitfall, amiodarone optic neuropathy is not the same as NAION, as I've seen that show up from time to time. And then the other thing that I'll add in here that we haven't discussed because it's kind of popular right now is GLP-1 receptor agonist drugs implicated, well, I'll say instead of say associated with higher risk of NAION, but association remains unclear because there's still a lot of study on that and we don't have great data on this just yet. All right, so then this graph edges is really interesting, and this is what I really like about how AI constructed this tool, is that there's all these different associations or relationships that each node of concepts relates to other concepts. So say, for example, NAION, maybe we can say manifests as sudden vision loss, right? It has let's see, we'll say mimics amiodarone optic neuropathy, and or I could look at the other way around. And then there's a little weight, so it tells you just how strong that association is. So maybe we'll say it starts out with a weight of 5. This one maybe a weight of 1 or something like that. But there's a whole bunch of different things. These are just the ones that AI came up with, right? So contraindicates, if you're saying, well, that might be a relative contraindication to cataract surgery. That might be something that some people might describe, but not necessarily. Complication of, same thing. We might say of, so, we've seen NAION show up after high volume dialysis. So that might be a nuanced factor. And a lot of this can get added in as we learn more and more about the disease. So this is just kind of a very detailed but basic way of taking the text that we have here and putting that into a framework that helps you understand and learn all of this information. And the whole goal of that is the more connections that you form between, say, this and the other things that you learn, it'll help illustrate the way all of this information relates to each other, so that whenever you see somebody in the clinic, you won't be thrown off by trying to come up with what's your differential for sudden vision loss, which is going to be super long and super it'll be super long, and that could be very challenging to generate de novo, versus just being able to think through, well, this person has sudden vision loss, it's painless, and it also has disc edema, my main concern being NAION in that situation. I am going to put in a nuance here because even though it's typically painless, about 10% have pain. So we'll say 10% have pain. Okay. But those are all just kind of some ideas, and then I can add the node, and then it gets added in here, and so I can look at that later right? And as I continue to build out all of these relationships, it'll start connecting to each other. All right. So hopefully this was interesting and kind of a neat way of learning how to study. I suggest, even if you don't have AI create something like this for you, you can always just put together this into a notebook or onto some sort of text editor, word processor that you can continue to update. And the more you can update that with all of these different connections, the better your overall understanding of ophthalmology will be. All right.